medicine's a team sport. Having that whole team focusing on people's medical health, their emotional health, their lifestyle, their risk factors, their health overall, that's actually what helps get people pregnant.
Miscarriage is a topic that gets missed. It happens so commonly, and yet we don't talk about it. So we need to shine the light on it. So thank you so much, Dr. Garbedian, for being here. You're a fertility doctor in downtown Toronto. Do you want to speak more to that? Because I don't know what I'm allowed to reveal, what I'm not allowed to reveal.
So right now, I am an OBGYN and I'm an REI. And I was working at Pollin Fertility for quite a while in the downtown core. And I recently left to join Pollin Fertility or Pollin Reproductive Health. And we're building a fertility center in Midtown Toronto.
Awesome. And so excited to be talking to you because like I said, it's a privilege that you're speaking to us. And I know your time is important to you. And, but the main piece is like, we got to get straight down to business. And for those of you who do not know who I am, I'm Mary Wong. I also have a practice right in downtown Toronto. I own a live holistic health clinic, which is more of a complementary fertility center. And we work with lots of people going through their lives from trying to conceive all the way to menopause, really. And we want to get you through it and boost your energy and make life a little easier, less lonely, more hopeful. And so here we are. So we want to go straight on to the topic of miscarriage. So first of all, what is it? What's the definition? And, there's a couple of things about it. So I think we need to do a deep dive on them.
Yeah. And I think whenever I try and talk about miscarriage, I always want to start by saying, yes, we're going to talk about definitions and about miscarriage, but it's important to say every miscarriage matters. So whether it's a very early miscarriage or it's a later miscarriage, they all matter because they have a significant physical and emotional impact on patients. So the definitions aren't meant to say which ones are more important or more significant. They're just a way for us to help classify them because at the end of the day, every miscarriage really does matter.
And I love that you speak to this because some people, and we'll talk about this too, it's like some people say, I think I had a chemical, but does that not count? And I'm like, of course it counts, right?
It absolutely does.
And first of all, what it is, right, compared to like a regular miscarriage. So you can go through the different kinds of miscarriage.
Yeah, so a biochemical miscarriage, and the reason I said every miscarriage matters, actually a lot speaks to the biochemical pregnancy or the biochemical miscarriage. And what it is a very early miscarriage. So it's called biochemical because we can detect your pregnancy hormone or your HCG in your blood, but the levels are so low and it's so early that we can't see anything in the uterus if we did an ultrasound. So, a lot of times I hear people say it's just a biochemical or you're just having a heavy period. None of that is true. So it's not a biochemical pregnancy. It's a miscarriage. It's just a very early miscarriage. And it's not a heavy period. It's bleeding from a miscarriage that is similar to a heavy period. And I think I'm always careful to say that because that patient still had a positive pregnancy test. They were still excited about being pregnant. They probably followed those levels for a few days to a few weeks. So that is a miscarriage and people can still grieve that miscarriage. They still have symptoms from that miscarriage and there's still sort of psychological consequences from it. So the definitions of miscarriage aren't meant to say which ones are more important or if one is less important than three. They're just ways for doctors to research things so that we're comparing things that are similar. So when you do research studies, you want to compare same pregnancies to same pregnancies. There are ways for us to look at prognosis for patients, to talk to them about that. There are ways for us to classify what investigations do, what treatments do, but every miscarriage matters. They're all important and they should all be treated importantly. And we should be looking at the physical part and the emotional part for every single patient, right from that biochemical to the clinical. The clinical miscarriage, that's us saying, and there's a little bit of different definitions and different guidelines, but it's when we can see something on ultrasound. And most of the time, what we mean is around 5 weeks, we can see a gestational sac, which is the starting growth of the pregnancy. Some sort of studies and some literature classify it with a heartbeat, but I would say most of the time we would say it's a clinical pregnancy once we start to see the pregnancy develop. And then once you have a clinical pregnancy, when you talk about definitions, there's so many definitions within that. So there's, is it a threatened miscarriage? So that's a term that people hear a lot. Threatened miscarriage causes a lot of anxiety. So it doesn't mean the patient's going to miscarry, but it means something is happening that is making us a little bit cautious about the pregnancy. The most common thing that provokes women to go into their doctor to get investigated would be bleeding. So bleeding is extremely common in early pregnancy. So up to about 20% of women are going to have sort of that early first trimester bleeding. They call it implantation bleeding, but we all know implantation happened way before the 6-7 week mark of pregnancy. But it causes a lot of anxiety. So it's common. It doesn't often lead to miscarriage. So most of those pregnancies go on to have healthy pregnancies, but it causes a lot of stress. So as doctors, there's not a lot we can do to intervene. And we'll talk about some of the things we can, but a lot of the studies show caring about that patient and doing what we call TLC actually reduces the risk of miscarriage. So that would be talking to patients to reduce their anxiety, talking to them how common it is, how most of them go on to have healthy pregnancies. Doing blood work will reassure a patient often that to see their hormone levels going up. Doing ultrasounds, so successive series of ultrasounds, so to follow the pregnancy. And that has actually been shown, that type of intervention decreases miscarriage risk. So it's really important when you are having those symptoms, whether it's pain or bleeding, to actually go see your family doctor, go see your OB or your fertility doctor and have that kind of intervention. And probably I imagine what's happening is you do the ultrasound, you're having spotting, you see the heartbeat, you see that the baby's developing properly. Your stress hormones go down a little bit. Once you start to get a little nervous again, you come back in, we do the ultrasound again, and they're going down. So treating the whole patient, not just the physical symptoms, actually reduces miscarriage. It's also important to do it because there are some things we can do, right? So we had talked before about progesterone. So there is some evidence that vaginal progesterone suppositories, something like prometrium or micronized progesterone, actually has been shown to risk of miscarriage, especially in women who have multiple miscarriages. So when you are having those symptoms, don't stay home, Google, oh, it's common, I'll just stay at home. No, go in and see someone, go see your family doctor, go to Emerge, obviously, if the bleeding is heavy, because there are things that we can do. And those ultrasound and blood work actually are an intervention that's been shown to reduce risk. So when we talk about threatened miscarriage, I always say, well, what's the most common cause of that bleeding? So why do women bleed in early pregnancy? So if it's not a miscarriage, it might be something called a subchorionic clot or a subchorionic hematoma. I stay away from the word hemorrhage because I kind of feel that's a triggering kind of word. And yes, I think when a patient comes in bleeding and I'm like, you have this thing called a hemorrhage, that is not going to decrease their stress level. So I would say a lot of doctors use the word subchorionic hematoma. And the way I describe it is there's all these little blood vessels around the gestational sac and they're friable. And sometimes they just break and you get this sort of clot. And the clot is actually a good thing because it's a way to stop the bleeding. So if you think of if you get a paper cut, you put a Band-Aid on, it stops the bleeding. You can't really put a Band-Aid on the uterus. I can't do that. But if you didn't put a Band-Aid on the paper, right? I wish I could, but I cannot. If you have a paper cut and you just leave it there, eventually your own clotting system will clot off that cut for you. And that's what that subchorionic clot is. So it's not necessarily a sign that there's ongoing bleeding. It might actually be a sign of old blood. So sometimes even just saying to a patient, actually, it's just brown blood. So it's scary. It makes you uncomfortable. But the good news is brown blood's usually old. So it means your body's done exactly what it's supposed to do. It's formed that clot. It's stopped the bleeding. And what you're seeing coming out is actually what happened maybe last week. And we're just seeing it now. Even when it's red blood, what we're really looking for is that expanding. So why are we doing all those ultrasounds? Is the clot stable? So has it stopped bleeding? Is it getting bigger? Those are all things that we're looking at. And when I say they're common, they're actually really common. So we did a study when I was at my last clinic where we looked at women going through a frozen embryo transfer and how common are those subchorionic hematomas. It was about 50% of patients.
Oh my gosh, I love it that you say that because I just through our own personal patients, that's what I actually tell them. So I was like dying to hear what you say.
It is
50%, and especially for those that actually go to a fertility clinic. So I love it that you say that. And of course, again, that does not necessarily mean miscarriage. I mean, people see blood and they automatically assume the worst, right?
And not every subchorionic hematoma has bleeding. So so fertility patients, I always tell them, you are more likely to be diagnosed with one because we're looking all the time. So for patients who aren't fertility patients, they may not have an ultrasound until they're 11, 13 week in that IPS testing. So for fertility patients, we're looking at 6 weeks, 7 weeks, 8 weeks, 9 weeks, 10 weeks, 12 weeks. And so sometimes when we see it, and not only that, most of the fertility clinics in Toronto use True North imaging, and we know that they're very good at what they do, and they have really great ultrasound equipment. So we are going to find all those asymptomatic, like tiny 1 centimeter subchorionic hematomas that a lot of patients probably have in the general population. They just don't know about it because they're not having pain, they're not having bleeding. So generally, when a patient comes in to see me, it's usually an asymptomatic, what we call an incidental finding. So our nurses go in and say, you have this tiny 1 centimeter, you might bleed. So the reason we tell people is because you might bleed. So we usually warn them, over the next week or so, you might get brown blood. That's okay because that's old blood. You might get red blood. So don't be worried because that's probably why it's happening. But you need to call us because we need to bring you in and we need to make sure it's stable, not growing, and to reassure you. So when I say 50%, that's actually a pretty high number. And when we did the study, we presented at the CFAS, or the Canadian Fertility Conference. And what we showed is that I think less than 5% of those patients miscarried. And the majority of them actually had no symptoms at all. So it's common. And I always say common doesn't mean don't worry about it because it's bleeding. So, I've been pregnant before, you've been pregnant before. Any bleeding in pregnancy is scary and it causes a lot of anxiety. And again, going back to what I mentioned before about TLC, call your fertility clinic, call your family doctor, because the more we can decrease that anxiety and make you feel better, quality of life wise. So I always tell my patients, like, I want you to come back in a week, but if you need to come back in 2 days, come back in 2 days for an ultrasound, because I don't want you lying awake at night. I don't want you stressed and anxious. I want you to feel better. And and people say, well, what about that is an intervention because I'm in a miscarriage. I'm not just treating the bleeding. I'm not just looking at the medicine risk. I'm treating the patient's emotions. And when we know from studies, the emotional part is so important because there's some long-term studies that are looking at 9 months after a miscarriage, almost 20% of women are having PTSD, moderate to severe depression, anxiety. So anything I can do during that experience to better take care of them emotionally is better. Right. So
I'm going to plug in then. I'm going to just jump in because what you may not know is that we do a lot of that support. So people think of acupuncture, maybe just the pre and post embryo transfer treatments, but we say it's so important and crucial, especially, during your 2-week wait. And then thereafter, when you're pregnant, we actually recommend people to come in weekly because to mitigate that stress response, which can be so huge, especially if you've been trying for more than a year, right? Like, getting pregnant is just one thing. Once you're pregnant, there's still a whole other anxiety level, right? So it's like we need to address that. We don't want that to become an issue. And then if you don't mind me adding in too, and I love that you mentioned not everyone gets bleeding. People may get bleeding, and it can be certainly alarming. And sometimes the alarm can be so much so that you can actually get a big chunk of blood that comes out. Like absolutely. Clot, and then you freak out because you think, oh my gosh, I just miscarried. Yeah, and absolutely. And it's literally the clot that comes out, the hematoma.
And you can see the hematoma. So and I think the first thing, going back to what you said, is, medicine's a team sport. And, especially when you're caring for a fertility patient, there's a lot of people that are providing that support. And obviously I can't be everywhere. I wish I could, but I can't. So having, you doing that, having the nurses doing that, having the naturopath doctors doing that, having that whole team focusing on people's medical health, their emotional health, their lifestyle, their risk factors, their health overall, that's actually what helps get people pregnant. So, you don't have to go to one doctor. The important thing is to go to a team that supports you from all different ways. And I think patients get something different from all of us. And I think the more we do things like this, where we talk about miscarriage together, people can see we're actually all really aligned. We're not as far off as as some people may think we are. And if we all work together to care for that patient, including, mental health support and things like that, we're going to have we're actually probably going to have lower miscarriage risk because we're caring for the patient, from an overall perspective, but we're also going to have less consequences after the miscarriage, because sometimes we can't prevent a miscarriage no matter what we're doing, but we can maybe decrease the risk of having that, post-traumatic stress disorder, having anxiety, having depression? Is there something we can do to make that after miscarriage care better? So, and that requires that sort of team support and kind of thinking of miscarriage as more of a physical thing. And it's just a lot bigger than that. And when I say support, obviously I'm not talking about partners, but male partners as well. So, fertility, miscarriage is a huge impact, a huge stress on marriages. So sometimes that support falls in sort of overall just counseling and making sure both partners are okay.
Yes. Yeah. And sometimes, women are going through it alone as well. And in those cases, for sure, you definitely need the extraneous help and support. And that could be, through family and friends, through health professionals of different types. And I mentioned again with acupuncture, I don't know if you know this, but also through studies, we know that it does literally mitigate stress response. It decreases the sympathetic nervous system. It helps with the parasympathetic nervous system response so that you're more calm and collected. We see endorphins increase, decrease of, the adrenal cortisol. So there's a lot of ways that we can help. And so I love that you're mentioning first and foremost that it's like you might want to refer to a team and, to make yourself feel more at ease through this.
And it kind of goes along with that study. The study is showing that just doing blood work and ultrasound has a significant reduction in stress, therefore reduces miscarriage rate. So if acupuncture is reducing people's anxiety and stress levels and stress hormones, I imagine it would have the same impact than that intervention would. So all of those things are important. And the important thing is to support patients. We talk about the threat of miscarriage being the bleeding, but there's also this sort of category of uncertainty that's really hard for patients, which is we're not sure yet ultrasound. And when patients come in and we do a 6-week ultrasound, we're expecting to see a 6 weeks pregnancy. We're expecting to see, appropriate growing baby. We're expecting to see a heartbeat. And I actually find there's not enough attention paid to that massive amount of stress when I say everything's not perfect. We don't quite see the heartbeat yet, or you're measuring a little behind, and women have to come back week after week for ultrasound to see if they're going to have a miscarriage. And a lot of those, not all of them, may end up in what's called a miscarriage, which means the pregnancy stopped developing at 6 weeks. So when we're scanning at 8 weeks, the reason it's behind is because it stopped developing. But sometimes what happens is your dates are different. So the reason we have to do all of those miscarriages, because we know this is a wanted pregnancy. Before we do anything, before we intervene, we need to make absolutely sure that this isn't a healthy pregnancy. So as much as I know those weekly sort of ultrasounds are stressful for women, absolutely, is the importance is making sure we're not intervening on a pregnancy that is actually healthy, because sometimes you just ovulate a little later than you think you did. Sometimes even when we do IVF, we put those embryos back. We think we know exactly what you should be. And, the babies are a little bit off. I mean, just like you think at life, everybody's a different shape and size. And sometimes babies don't fall on curves. And when we talk about nomograms and normal values in medicine, we're talking about the middle group. There's always going to be outliers, high and low.
Absolutely.
So even though I know it's that stressful, so how can we better support people instead of saying, I'm not sure yet, come back in a week. So part of that is we need that emotional support. So whether it's acupuncture or seeing one of our counselors, whatever we can do in that week that is less stressful for the patient is the important thing. And sometimes, as I said before, a patient like, I don't think I can wait till Monday. Can I come in? And the answer is you don't want to do the ultrasound too much because you're not going to see change, because we're talking about like little millimeters. So it might, and this is where you have to treat the individual patient, because for some patients, coming in every day would increase stress. They'd be like, can I just come in 2 weeks from now when we know for sure?
Yes.
Other patients are different. Like they know it might not make a difference, but they need to come in every day just in case the heartbeat shows up, that they didn't want that 3 days not knowing that it was there. And so I think whenever, when I think about Pollin and I get to kind of go back and reinvent all our programs, the most important thing is saying, these are the guidelines, because you want your doctor to be evidence-based. You want to know, I've read every study, I know every study, I know the evidence inside and out, but you also want to know that I'm caring about you as an individual. So part of that is taking all those guidelines and evidence, but individualizing the care for the patient. And when you have something like miscarriage that's physical, and psychological. That's why the art of medicine comes in, because not every patient. So if I put a rule in that says we can only see people every week, I'm missing those patients that actually would really benefit from seeing the ultrasounds more. And there's also that group of patients that are like, I don't want to come in every week. Like, please, like, let me come in 2 weeks. So that we need to be able to respond to that, to individualize the care for the patients. And I think that's sort of the vision I'm going through, whether it's our miscarriage program, our fertility program, we're our third-party programs. We're trying to say, okay, well, these are the guidelines, because everything's going to be evidence-based. We're evidence-based doctors, but how can we individualize these programs and tailor them to the best needs of the patients, the couples, and whatever that couple structure looks like? So how are we going to make care better? And I think part of that is individualizing care. Anytime you do the same thing for everybody, again, not everybody's the same. You're going to miss people on either end. And I think and the goal for miscarriage would be, how can we better get access to resources like mental health resources, like acupuncture, incorporating naturopaths, having more nurses and fertility coaches to provide that support, and access to me. So I think one of the things I hear from patients the most when I'm either going on the internet or doing things, I see people say, I wish I had more time with my doctor. And I think part of that is making sure there's time in the day to be talking to those patients. So, to make sure it's me that's, talking to my patients. So making there more resources for the patient, but also making sure they have more time with me too. And so I think that's what helps the most.
Yeah. So thank you so much for addressing this, because this is certainly a concern, because you're right. When we get trapped into the cookie cutter approach, it's like you just follow the mainstream, and it is a protocol based thing. And it's like, no, you're just giving people full, rights to say, hey, I need to self-advocate and say, this doesn't work for me. I get that this might be the protocol, but
the guidelines.
I need more help, or I need less, right? So, and because you are 100% right. It is exactly that. Some people will get more freaked out the more tests they do, because it's kind of like, all right, I might maybe pass this test, but then as soon as I'm out of the office, I'm happy for like 15 minutes, and then I worry for the next one.
Exactly.
Right? So, and that's one person. And then whereas the other person may say, you know what, I feel more in control the more tests I have. And that's all individual.
And it's very individual. And I think people, like I said, whether it's an earlier miscarriage or a later miscarriage, everybody's different. So you can't assume anybody is going to feel any way. You need to provide the same supports for everybody. So when I keep getting asked, are you creating a reoccurrent pregnancy loss program? And the answer is, I am definitely a specialist, a subspecialist in reoccurrent pregnancy loss, but I'm actually creating a pregnancy loss program. We're going to care for women right from biochemical all the way to their third or fourth loss. And by individualizing the care for each person, we're not missing anybody. Because for my goal, it's always, I know the thing that patients always say to me is recurrent pregnancy loss, and that to define it, it's a tricky one, because everybody defines it differently, whether it includes the biochemical pregnancies or it's just clinical, or sometimes in the literature, it's 2 versus 3. Right. At the end of the day, we just need to prevent the next miscarriage. So if I'm going to restrict all the resources until someone's had a few miscarriages, that doesn't make sense, because what can I do now that makes sense? It's still evidence-based. What can I do to prevent the next one, to prevent the person that's going to be the recurrent pregnancy loss? So that's why you can't just have a program focusing on that. You need to focus a program on the whole spectrum, so that you can kind of make sure everybody gets the physical and emotional support, but also make sure someone's paying attention to make sure they don't end up on the other end.
So I'm paying attention to time, and I think we're going to wrap this up. But guess what, everyone? We are going to do more deep dives on this subject, and it'll come out in about a month or so. So I'll definitely let you know when that comes out. But before we actually wrap it up, let's just kind of recap, one tip, one most important point that you think that we walk away with today.
I think going back to what I said at the beginning is every miscarriage matters. Every miscarriage is important. Every miscarriage has a physical impact, an emotional impact. Every miscarriage, it needs attention. It's important. And patients should feel valid, whatever their feelings are, regardless of the miscarriage. And go to a practitioner that also feels that way. So if you need to feel validated, if you come to me with 10 million things off of Google, you want to know that I'm sitting with you and going through them and saying why they do or don't pertain to you. So, treating you as a whole patient also means figuring out, what do you know? What don't you know? What are the things you're Googling? Because let's be real, we all Google. I Google myself sometimes. I'm a Googler too. And I want to know the things that they're wondering. Because if I just say, no, I'm not going to do this test, or no, I'm not going to do that, they're going to leave not feeling like they had the best interaction. So by taking each patient as an individual and treating them and figuring out what's important to them, what is causing them anxiety, what is the thing they worried about? What's the test that they can't sleep at night until they have done? What is, do they want progesterone? What's their worry about progesterone? So I think the most important thing with miscarriage is go to someone that you feel comfortable with, go to someone that's listening to you, that's validating what you're saying and caring about more than just your physical symptoms, the whole part of it. And obviously going to lots of people, getting that support. If you might not be getting it in one place, going to your acupuncturist, going to your counselors. So that whole holistic approach.
That's awesome. Thank you so much for your time. And guys, you need to tune back in, because we're going to talk more about, what can we actually do? We kind of naming, like we're like skipping a lot of things here.
A lot of stuff.
We're going to go more deep into this because we need to.
Absolutely.
And so we'll talk to you guys later. Join us again.